So it is my pleasure to invite my colleague Dr. Carlos Abril to talk about indications and operative steps of sleeve plus procedures. This is something that I'm actually looking forward to hearing his talk and his data. Dr. Abril.
So, good afternoon. I know that it's hard to listen to anyone now after the lunch. So I will try to shout so you don't get bored and you don't get sleepy. So they were talking about indications and operative steps in the transit by partition, but I like always to say that the transit by partition, in order to let people what this is the natural GLP. Everyone is loving GLP, retatrutide, tirzepatide, all the GLPs medications, so probably this is the natural one, this is the best medication that we can have, and I'll try to convince you today. In June, last June, my mother, who's 94, she broke her hip, and she recovered perfectly, even though she's 94, and I was coming back from her surgery, and that's my house, and I saw the moon and the star, and I was thinking about, look, like the Pakistani flag. And that's why I took that picture, because it's not usual to have that image back home where we live. Say, okay, I need to show them that we have part of your flag some nights in Valladolid. Well, talking about bariatric surgery, probably one of the first surgeons were done to this gentleman. This gentleman, he was a king in the 10th century. They called him the Fat, and he lost his kingdom because he was fat. He couldn't even ride a horse. His grandmother, who was a queen in another place, had a friend. They were Christians. The friend was the Khalifa in Cordoba. You know, at that time, Spain was, the owners were the Arabs. They were there. So the Khalifa was the king of Spain at the time, and his doctor, who was a Jewish Spanish guy, was a very well known. So the grandmother asked Khalifa to help his grandson to lose weight. And probably that doctor was the first one, to practice a surgery, because he stitched his mouth, and he lost weight. He could come back, he ride the horse, he recovered his kingdom that he lost later, because one thing is that he lose weight, but they didn't give brain, so he lost the kingdom again. And it's nice to see this commemorative thing for that doctor who was Jewish, and you can see in the same place the Christian, Muslim, and Jewish signs in the same monument. But the first surgeon for bariatric surgery was this guy, Edward Mason. He was the father of bariatric surgery. He did in the past room-wide gastric bypass. He never do a room-wide, but he did a gastric bypass in 1967 probably. He was a pioneer, and probably without him, we wouldn't be here today talking about bariatric surgery. And we owe him his contribution to bariatric and metabolic surgery. Of course, gastric bypass with then done laparoscopically by Whitrow, and many other surgeons that we have to be thankful. And the way surgeons work is that we do something, we see it works, but we don't know why. And that's this paper, written in 1995 by Walter Porris, said, who would have thought it? So we did something without knowing that we were curing diabetes. Walter Porris is the famous cartoon, is a surgeon, but is a famous cartoon drawer apart from surgeon, and is one of these jokes about bariatric surgery. Randomize me into a surgical group, because it really works. That's what we've done all our lives as surgeons. We created procedures, We invented them many of the times because we are not humble and we want to put a name in the surgery procedures that we're doing, but they're working, but we don't know why. So in that time, the only thing what we did is to prove that bariatric surgery was safe. We were claiming, no, this is working, and our patients are doing fine. And it's true. This paper from Ali Aminian is done in patients with diabetes, type 2 diabetes, and you see that morbidity of these patients in practicing a room-wide gastric bypass is the lowest among others like LAC-API, lap cholecystectomy, hysterectomy. If we go to mortality, there are only two things that have lower mortality than our surgery, which is a knee arthroplasty and laparoscopic hysterectomy. But even in lap-API and lap cholecystectomy, they have higher mortality in diabetic patients. Okay? That surgery is better than medical treatment, we all know. We all know there are multiple papers saying that. And you can tell me, okay, this one is from 2013. So at that time, probably the first GLP or analog exenatide could be in the market, but nothing special. But okay, I can give you another one from 2024, comparing to the first GLP ones, probably liraglutide. And we are still better than any medication. So, but we need to wait for scientists. If someone wants to know about the discovery of the GLP and the history behind that, this is a good paper to read about. Joel Habener, Lodi Knudsen, and Svetlana Moksov, they are the fathers of the all GLP stream now. That paper is written by Jeffrey Friedman. Jeffrey Friedman is the Lasker Award in 2009, and he was the one who discovered the leptin. So it's a very nice and easy read to learn about the GLPs that they are now. So GLP is magic. GLP can do everything. Decrease the glucagon production, increase the insulin sensitivity, decrease the glucogenesis, decrease the gastric emptying. So it's a magic bullet that now it's all over the world. But we have another magic bullets that we control because we produce these things as well. So if you're looking the fibroblast growth factor 19 among these 22 FGF factors, this is a very good, it's a product as well that is in a study to help the patients to lose weight. But we know that this factor is increased in patients doing bipartitions, increased very highly after doing bipartitions, immediately after, and it's not related to the fasting situation. So this guy, not me, the other guy is Sergio Santoro, who's a Brazilian surgeon and is the creator of a new surgery. He wrote this paper in 2007 describing the bipartition. All over the world, they know about the SASI, the SAG. Okay, but the real name of this surgery, and he was the one who invented this thing, it was a bipartition surgery because we don't exclude any part of the GI tract. There's no exclusions. Okay, so the food can go through the two tracts, the natural one and the one we create. So the bipartition could be gastroileal bipartition, could be one anastomosis, or could be two anastomosis like that one. And I don't know what happened with the screen. Good. Or could be a duodeno-ileal bipartition. All of them, they work. And why are they working? Well, when we're talking about room-wide gastric bypass, we're going to create a pouch. A pouch in the mini, a pouch in the gastric bypass is not a stomach. As you say, it's a pouch. In a bipartition, in a sleeve, even in a sari, in a duodenal switch, you keep the structure of the stomach. It's kept. So the movements are completely different because you keep the structure. The lesser curvature is intact. When you do a pouch, it could be long, could be small, you broke completely everything. When you have something attached in two ends, like the stomach is, you release one of them and the stomach will never work as it should work. So we have a long tubular pouch, which is not a pouch. We have the stomach. We don't have mechanical restriction even though we do a sleeve, because the sleeve in this surgery is not to create restriction, it's to increase the gastric emptying, to increase the speed of the food getting to the ileum, because at the end of the day, the gastroileal theory is the one that guides these surgeries. we don't need exclusions to achieve what we have. We start doing the surgery, bypass and room-wide gastric bypass, and we cure diabetes because we exclude the duodenum. This is not true. You can have this interposition, jejunal interpositions. These patients, after 20 years, you don't exclude anything. You only put the ileum in a closer space. And the GLP, even 20 years after the surgery, they have increased GLPs. Now the GLPs you inject, you lose weight, your diabetes get better, you don't exclude anything. Your duodenum is there. Why do you need exclusions to justify that you're doing a room-wide gastric bypass, that you're doing a SADIs, that you're doing a duodenal switch? Why do you exclude if it's proved that there's nothing? This is a paper done in rats, experiment, Xiaoding Su from China, great experience. They did a model with a sleeve, room-wide, and transseptal partition, okay? And what happened is that they realized that from a glucose perspective, the transseptal partition did the same as the room-wide. Why do we need small pouches? Why do we need to exclude segments? We don't need them. If you look at this paper from Geltrude Mingron, you see that the ones that they stimulate the ileum sooner, like the SADI and BPD, after the surgery, there's no peak in the glucose. If you look at the graph, the room-wide and the sleeve, after surgery, you have the peaks. Of course, they drop lower, but you have peaks. The same happens with insulin. In those ones with early stimulation of the ileum, like the BPD or the SADI, you don't have a peak in the insulin. You do have the peak in the room-wide. You do have the peak in the sleeve gastrectomy, even though after it goes lower, but you have a peak. And you know the peaks in insulin and peaks in glucose are what is killing us. And what's the thing? Jejunum and ileum are different. They have different cells, and then they have different behavior. What's going on now? We are eating edible things that they don't get to the ileum. No carbs, no proteins, no fats. They get to the ileum. They are completely absorbed higher up. What happens? The L cells are not stimulated, and that's why we've lost the GLP function. If to these benefits of non-exclusion, early stimulation of the GLP of the L cells, who are the ones producing the GLP, if we add that, if we do a bipartition in a patient with a sleeve gastrectomy, we decrease the pressure inside of the sleeve, and we drop the GERD from 29% in this study on 100 patients to 8%. So only decreasing the pressure of the sleeve, you decrease the risk of reflux after this surgery. So at the end, we have the perfect recipe to add to the sleeve the benefits of the sleeve with better metabolic surgery. It's not a bariatric thing, it's a metabolic surgery, because we are trying to create our own factory of GLP in one dose, and we are not supposed to inject anything. Every time we eat, the food will get there, and the GLP will start secreting in our bodies. Those are the steps, those are my steps. This is not the way you have to do it. This is the way I do it. And I will change it. If I have to change it, I will change it. But those are my steps. The first one, the mental split. I count the bowel. I count completely the bowel from the ileocecal bowel. I go backwards, and I mark in 250 and 280. And when I get to the traits, I will change that according to the findings. Then I do that. Why I put the 2 marks? To avoid any twist in the anastomosis. The sleeve, I do it in a 40 French Maloney. The gastroileal anastomosis of about 4 centimeters. It could be lineal, it could be Hansun, and 3 centimeters far from the pylorus. Then I do a room-wide ileoileal anastomosis. This is a 30 centimeters breach, only to avoid the bile getting to the stomach. I'm not against the mini-gastric bypass, but I'm claiming that I don't like the bile inside of the stomach. For me, it would be a bad idea to do only one anastomosis transseptal partition, and I prefer to do the room-wide transseptal partition. I close the spaces, and of course, I do NEGD in all the patients. So that's our hospital. This is an omental. You see the omentum is from a patient with SIC, that typical omentum of a metabolic patient with diabetes. You can see that. Many times you do surgeries. I always split the omentum, always. Should you do it? That's up to you. That's up to you. Some patients can have a small, but I like to do it, and it's like a mantra thing. I do it from the beginning, is the way I start. Then count the bowel. I identify the ileocecal valve, and I start counting. The patient is supine, both arms separated with the footboard, reverse Trendelenburg. I'm on the right side of the patient. Identify, and I count now 5 by 5 until I get to my 280. This one is an old video, probably, and I think I count this one as 10 by 10. Now I do 5 by 5. And what I do is to mark with clips. Now I don't use clips anymore because it's more expensive. But I mark in 1, in 2 meters, and in 3 meters. This video has a 4 meters too, but I only mark 1, 2, 3. Gives me a better idea. If I have to go back one day to do surgery, I can measure, the clips will be there, and I can measure the difference between before the surgery and after the surgery. And during the surgery, I know that my anastomosis has to be between the 2 clips and 3 clips. So I know that I didn't twist anything, I didn't make any mistake, because I think it's not appropriate, it's not acceptable that we fail in the surgery, that we need to know if we do it right or wrong. This is about connecting things. And now in this one I put a V-lock as the first stitch that I'm going to use later on in the sleeve. I put a lever retractor. This is a Book Walter retractor. That lever is thick and heavy, but not very big. It's not very healthy. Then when you put the patient, you start with whatever energy you have, very close to the stomach, until I get inside of the retrogastric space. After that, I used to do it twice. Don't tell me, do you have to do it? No, but I do twice all the time. So I do one burn, and the second one closer to the stomach. I don't care if I burn it or not. Should you do it? It's up to you. I sleep better, and I don't have many problems. Once you get close to the spleen, you have to be very careful. Of course, as my colleague said before, you need to expose the left pillar. So you can do a normal sleeve and a regular sleeve, because there's no difference between doing a sleeve here. So I always put the 40 Maloney before the first fire. I have reinforced all my staplers now. This is going to be Echelon, but you can use Medtronic. I use the blue load. I don't change it. I always make it flat, and I know that nobody likes that, but I get close to the 40 Maloney. That's why I'm using the 40 Maloney, because I'm pretty sure and positive that even getting close to the 40 Maloney, I'm not going to create any stricture or any issue with that. I always put a gauze there. I'm afraid of the spleen. Once I remove it, I start with this one, where I place the stitch at 280 or 290. I will start doing the anastomosis, the first layer posterior with a V-lock, and the other ones I'm going to do it with a Hanson with a PDS 3.0. Should you use a PDS, use whatever you want, but use something that you like. Could you do it with a linear stapler? Of course. Now you do it. It depends. If you want to be faster, you do the linear stapler. You want to do it Hanson, you can do it Hanson anastomosis. I do it in the all length. Then opening is tricky. It's very tricky sometimes. If you don't do it right, you start digging between the mucosa and submucosa, and you create a tunnel. So you have to be sure that you're inside of the stomach all the time. I do it on top of that tube, and then I like to mark the length of my anastomosis in the stomach. I don't know if I can sorry, I didn't want to do that. I wanted to sorry guys, how to advance this, because I would like to geez, let me see if I can fix this. Usually we can have, well, it's a pity. It's a pity.
Carlos, you're using your own laptop?
Yep.
You should be able to sort of,
Yeah, that's what I wanted to do, and I cannot.
yeah, Atif is coming for help.
Yeah, I should be able to advance the, I should be able to advance this thing, and I cannot.
It's not showing here.
Yeah, that's the point.
Yeah.
That's what I
Because,
wanted.
Did you select the loop running? Because then it shows when you format.
Yeah, no.
So let it run, we can watch it.
Yeah, so
But few minutes.
I
Because if you
cannot.
click, then you will go to the next slide.
Yeah, correct. So I will leave it.
Yeah.
So I can talk and tell you about, you can leave it running. So 9 minutes, one. So once I do the anastomosis, so
So
then when I do the anastomosis,
after you demonstrate the technique, is there more presentation or we can start asking questions while this is
you
running?
can ask questions because the next presentation is yours. I think we have time. We had 20 minutes already completed or not?
So you have got another 3 minutes.
Okay, so we can talk about this. I wish I could know how to do this.
So the next step after, so where we
Once-
stopped, you were doing the
So once we do the
allele-
anastomosis,
Yeah, anastomosis.
so
then what do you
once
do?
we finish that with anastomosis, what we're going to have is one anastomosis transit by partition because it's connected only to the ileum. But as I told you, I have to be honest with you, the first one I did, it was one anastomosis because I said, okay, I'm not going to do the second one. Because the second one is the most tricky one. So, but now I don't do it anymore. Because of what? Because of that, the bile. So every time I scope my patients after one anastomosis, some of them, they don't complain, but I see a lot of bile and the stomach is red and inflamed. And that's fine because the patient is not having pain but or issues now. But that patient is going to live 30, 40 more years. What's going to happen with that? I'm not happy with that. So now I'm doing it room-wise. So what I do, I transect the afferent limb and I join it like 30 centimeters down the line of the rule, creating the iliac bridge. And I do an end-to-side hand-sewn anastomosis. What I do end-to-side, I think the side-to-side anastomosis that we're doing with the room-wide gastric bypass, they get dilated. Many times you go back to your room-wide gastric bypass and you see the JJ is like a bag. Why? Because every time we do a side-to-side, the bowel loses the structure to move. Because you break it. You break the way he's moving. And that's why you get and you see very dilated. And is that the reason of the pain? How many patients do you have with the left upper quadrant pain after room-wide gastric bypass and you don't know why? Could be the JJ, could be or not. Intussusceptions, the J inside of the J. With this JJ end to side, theoretically, I don't have data, of course, theoretically you shouldn't have intussusceptions and you shouldn't have this dilation that you have. So of course I close the spaces. The only way I don't close them, if it's very difficult, I prefer to not to close it, that close it wrong. So it's better to close it or don't close it, but don't do it in the middle. Because if you leave a small hole, that's the one that's gonna create a big complication.
So some questions, Carlos, while you.
Yeah,
So-
yeah, so yeah.
He's also a big proponent of this procedure.
In one anastomosis.
Atif, your mic is not working.
Is the battery of the...
Big proponent of this procedure, and he told me while discussing this is very good for thin diabetics, and he has done this procedure in low BMI people like 22, 23 BMI as well.
For diabetes.
Yeah, for diabetes, this procedure. So had you any experience of doing this procedure in low BMI? Because as you mentioned, there is no caloric malabsorption in this procedure.
Well, theoretically, because there's no study, we don't know in numbers how much it goes through the normal pathway, but it goes, I can tell you. If you, for example, do fluoroscopy on these patients after the surgery, if you wait enough Because many people, you drink the contrast, they take the pictures, and the first thing you see, and is what you want, is that the contrast goes from the sleeve, it goes to the ileum. That's what you want. And then if you stop, then you will see, okay, everything goes to the ileum. If you wait, and you don't wait that much, you can wait a couple of minutes, you will start seeing that the contrast goes to the duodenum. How much it goes, there's no study, so if you want to start doing these things and doing this study, you will, okay. This is probably the JJ, or is the, no.
Gastrojejunous.
Is the DJ. So it goes through the duodenum. So theoretically, the patient shouldn't have that much iron deficiency, that much calcium deficiency, because part of it goes through the regular pathway. So at the end of the day, what you want is that the food goes rapidly, the nutrients, so carbs, fats, and protein, they stimulate the L cells, which are much abundant in the ileum than the jejunum. Jejunum has but very small amount. The majority of the cells in the jejunum are the key cells. Why do you think those patients after room-wide gastric bypass, after many years, they start developing those hypoglycemic hyperinsulinemia? Because there's a hypertrophy of the mucosa of the jejunum. When that happens, and you will see that, if you do your bypass and you count, I'm going to do a rule in 150, you go back years later, and your rule is 90 centimeters. So where did it go? Disrinked, because there's a hypertrophy of the mucosa. It means that there are more cells, more key cells. What happens? Those patients that I've been doing good, and now I'm eating some carbs, and then I have this dumping syndrome, which is a hypoglycemic hyperinsulinemia. Why? Because you have such amount of receptors, such amounts the GLPT5, such amounts of key cells that they are sucking the simple sugars from the jejunum. That doesn't happen in the...
Carlos, you're back on your operation, so...
Okay, so I section the afferent 1. I don't know if we're going to do the scope now. Always do a scope to see that we traverse, we don't stenose anything, it goes well, and there's no leak. And then this is the ileoidal anastomosis. As you see, I'm going to do an end-to-side anastomosis. This one is going to be 2 anterior, 2 posterior. I don't do 2 anterior anymore. This patient is a lady that her BMI was 48. She was diabetic. Currently, her BMI is 22, no diabetes. She's doing fantastic, but this patient had, the first days, has a huge distension of the BP limb. Because I had an hematoma anterior in this anastomosis, and it took a while until it passed. What's the good thing of this surgery? You will not have the problem that you have with the roux. Because if the roux is not draining, you're going to have a big problem, because you're going to distend the remnant. Here, it can go backwards, but you will never blow up anything, because it's like a circle. There's no exclusion of any limb, which is a good thing. So now I only do 2 posterior and 1 anterior.
So Carlos, while we are watching this,
Yeah.
so how is this operation metabolically superior to SADI? Or for weight loss? So you're doing it as a revisional procedure. Why is it better than SADI, or is there data?
So there's no data. I mean, think about it first. ACMBS and IFSO, they are still in the process of approving this surgery. They haven't approved this surgery.
But there must be data from somewhere.
No, data there's, but no comparison, no randomized control trial comparison with SADI. But the difference is pretty similar to the SADI outcome, weight loss and morbidity resolution of comorbidities, and less nutritional issues.
Okay.
Less weight loss, probably, but that's what we're waiting for. But think about it. Why people, knowing that the SADI is a good surgery, and don't forget another thing. You are not excluding the BP limb. How many of these patients they're going to need any biliary tree manipulation? Can you do that with the room-wide? No, you can't. Can you do that with the SADI? No, you can't. Can you do that with the DS? No, you can't. Can you do that with this? Yes, you can. You can do that. You can access the biliary tree. You can access that, which is a big deal in these patients.
Okay,
What if you have any complication or any problem?
thank you.
Whatever it is.
We got the gist of that. Any other questions from the audience for this topic? So, for how long you've been doing it? How many cases you've done?
102
Okay.
since January 24. I need to collect all the data, but I can tell you, except one patient was a diabetic patient, didn't do very well yet. Rest of them, I can tell you, I don't see, that's my personal impression, of course. I don't see any difference from patients that I've done studies with BMI over 50. So I've done these patients, this surgery, I've done it in patients with BMI over 50. Of course, how could you adapt this one to your patients? That's a different story. I think papers and publications and data are related to your own population, which is completely different, because the food, the culture, many things are completely different, and you need to adapt that. I can tell you, I've never seen SADIs, for example, back home in Spain. You can expect 3-4 bowel motions a day. Here, there are patients with SADIs with constipation in Abu Dhabi. Constipation, and I'm doing at 280. 280, not even 3 meters. So, why? Because it's different. The behavior of the population is different. What they're eating is different. And that's why you need to adapt to yours. I don't know if you have to do it at 2 meters, at 250, or you have to do it at 350 because of the issues with the food or the bowel motions. You need to adapt everything to your population. So every time we read the paper, we need to be very careful, because that applies to their population, not to yours.
So are you offering this procedure to all of your patients?
All of my patients.
All of you?
All of my patients. Nowadays, all of my patients.
So you go through procedure is this?
Sorry, can you use the mic so that everyone hears your question?
So my question was, if you are offering this procedure to all of your patients,
Yeah.
and you said yes.
So this patient, this surgery, we are doing under IRB in our hospital. So we did everything under the law to avoid any issues. So
every patient you performed this surgery, you did 2 anastomoses, gastrojejunostomy and jejunojejunostomy, sleeve
Correct.
jejunostomy and jejunojejunostomy.
correct, too.
Almost 4 years back, when I was in training, we did almost 350 cases with this sleeve jejunostomy. That is truly called SASI. Sleeve ileal bypass.
With jejunum.
Yeah, no, the sleeve ileal bypass. Actually made from ICJ, about 250 to 300 centimeters or 350 centimeters from the ICJ, and we performed almost 350 cases. But the malabsorption was so severe that we had to reverse some cases. But that was with a single anastomosis. Yes. Is it something related to single and dual anastomosis?
Of course, there are two things. When you do a single anastomosis, the mechanical movement of the bowel is completely different when you do one anastomosis only. Nothing is coming and pushing things inside of the stomach. And that created an irritation of the rest of the stomach, because bile is coming to the stomach with food and with the rest of the juices. So probably, but again, I don't know if I perform this surgery in your population, I'm gonna get all of them malnourished with diarrhea or with any other complications. Those are the things that you need to keep in mind.
Okay, I agree.
So I think thank you for sort of bringing something new to the table, and very interesting. My last comment from you, that do you think Pakistan is ready for this procedure?
So are you doing studies?
Very rare.
Well, but if it's very rare, this is a surgery that is easier to perform. So if you are very ready for studies, you are more suitable for this kind of surgery, definitely.
So for somebody who, for example, wants to start doing this procedure, are there any specific patients that should be targeted, like in terms of BMI or comorbidities, who are more suitable for this operation than the others?
That's
Is there any specific indication?
That's a very good point. So of course, like everything you start, when you start something, try to start with patients that they are not very high BMI, because you're going to struggle. Not because it's different. I mean, you've been doing surgeries. I've been doing the
So
bypass.
in terms of indication, not the ease of doing it, but in terms of real indications.
But indication.
Who will benefit
you tell
more
me,
from this?
You tell me you're going to start doing a sleeve in a patient. What's your indication for a sleeve?
So,
Tell-
so somebody who's doing all the procedures, is there any specific patient population who's going to benefit more from this particular procedure?
To me, all.
Okay.
All the patients. So you need to find, when they say indications, for me, is that now you need to find the contraindication for this surgery. That's the point. Of course, you would tell me, I have a patient with a grade D esophagitis, I'm going to be the first one to say, no, you are not. But I can tell you nowadays, even grade A and B, I'm glad to offer the surgery. There are a study ongoing of this kind of surgery in patients with grade A and B, disappearing completely the reflux. And I'm going to tell you, we did a trial with Dr. Gagne with magnets. We did this with one anastomosis with magnets, right? I had a patient, it was my patient, we did the magnemosis anastomosis, the MAGD, and the patient lost 10 kilos. It was a revision, the patient had a sleeve before. When I do revisions on sleeves, and I'm sorry, I do re-sleeve in almost all of them. But because this was a trial, we couldn't trim the sleeve. We couldn't touch it. We had to use 3 meters, and we have to be attached to the trial. It was a trial, so we cannot move from that. So we did the surgery. The patient lost 10 kilos, no more than that. But you know, when I see her every 3-6 months. Do you know her comment? She's really happy. Doctor, I stopped having reflux. That was not the purpose of the surgery. That was not. And of course, N is 1. Okay? But it's important to know how a patient that was suffering from reflux, you do the surgery, lost 10 kilos, she's not complaining about that. And what she really highlights is that I don't have reflux anymore. And she didn't change the diet. The sleeve is the same. We didn't touch anything. And she got better from the surgery itself.
So you recommend as a revision surgery in sleeve gastrectomy when there is a weight stuck or weight regain, we can convert it into this procedure.
Completely. So now he's going to kill me, but most of my revisions right now, I mean, I have a room-wide gastric bypass, I revise to this surgery.
Okay.
Unless there's a patient, okay, they want to revert to normal anatomy, and it's a hypoglycemia, for example, a dumping syndrome, that's fine. But for example, we can talk about this surgery, the risk in smokers, the incidence of, this is a series from Sergio Santoro, and room-wide, not one anastomosis. One anastomosis, there are higher incidence of marginal ulcers in smokers. But with room-wide transit by partition, Sergio Santoro have more than 1,000 patients. He doesn't have one single patient smoker with ulcers. It's very unlikely to develop ulcers in these patients. Very unlikely, in 2 anastomosis, not in 1. One anastomosis, they have a higher risk of having. We can discuss marginal ulcers. There are many reasons for that. We don't know why some patients are having some others, but the real thing is that they are not having these marginal ulcers.
That's great. I have been doing as a revision surgery.
I'm sorry, I'll have to stop it there. So because we are
We can discuss.
we are overrunning, we can discuss this over coffee break.